The reason for that is that I'm dyslexic. And that's actually one of the reasons I got into this field, because schooling was horrendous for me. I'm a slow reader, and the whole education for me was just a dreadful, dreadful experience. And so talking public, I had a huge amount of evidence that I was pretty stupid. In fact, my family was pretty worried I'd get through even primary school. So I've always had an interest in inequality and all that because of my personal experiences. And then somehow I managed to get through a very long PhD with learned about method mainly. And then working in the area of chronic disease self-management and working with Kate Lorig from Stanford University, who had this great measure, back then perhaps a great measure of self-efficacy built on social cognitive theory. And when I read these questions, there's no way I could understand these questions myself. Good grief. How could a patient understand these questions? This is after my PhD. And so I thought, we could do better than this. So we used a process called concept mapping to actually find out from people's hearts and minds, what do they conceptualise as a good outcome from taking part in a self-management course. This questionnaire really tapped into the lived experiences of people, and it got reproduced and used in many parts of the world. And I began to think, wow, questionnaires are pretty powerful and becoming famous. Change policy in the UK, used across the US. Kate Lorig and I no longer were good friends, but that's okay. We're competing in the world of academia. But then with this questionnaire led other questionnaires about decisions about who should have hip and knee replacement next. Should develop another questionnaire, influenza. Should this pharmaceutical company was actually investing hundreds of millions of dollars, potentially $1 billion in, should it be used now widely? So I began to take a big interest in measurement. And so an exciting part of this is just really developing good measures. I'm going to stand hand on my heart. Yes, a decision made by using this questionnaire about a patient or about a program, yes, that is a good decision. So exciting thing is the health literacy questionnaire, which we developed here in Australia, used in 300 studies around the world, is in the National Health Survey of Australia. I'll give you an introduction to what this questionnaire is shortly. So our Minister for Health will soon be, in March, from the ABS, the Australian Bureau of Statistics, National Health Survey, will be talking about the health literacy of Australia, which will skyrocket. It really will be a huge blast for health literacy research in Australia and a stimulus for other countries, we hope, as well. The New Zealand government also using the same questionnaire. So health literacy is incredibly exciting right now. There is so much policy going on with COAG, the Coalition of Australian Governments, the Australian Health Performance Framework, the Australian Commission on Quality and Safety in Healthcare, the Productivity Commission, My Health Record and NHMRC all have health literacy listed as a key issue. And there's huge international policy around the Sustainable Development Goals and the UN Sustainable Development Goals. It's incredibly exciting. It is our time to really rocket this research. So here we do have, very hard to see, I expect, a questionnaire that we use, which is administered to 1,400 Danish people who have diabetes to find out, well, how is their health literacy related to their HbA1c, the control of their diabetes, feeling understood and supported by healthcare providers. So all these dimensions, as I go through them, think about, does this tell me about the patient, or does it also tell me at times about the experience they're having with engaging with the healthcare system? So these are the questions of the health literacy questionnaire we developed here in Australia. Feeling understood and supported by healthcare providers, having sufficient information to manage my health, actively managing my health, social support for health, appraisal of health information, ability to actively engage with healthcare providers, navigating the healthcare system, ability to find good health information, and understanding health information well enough to know what to do. So as a researcher or a practitioner, you have all this information about a person or a program, you've got a pretty good understanding of their capability and their experiences of engaging with the healthcare system that we put in front of them. We actually found that having actively managing health, some micro skills around actually, can you organise yourself? Do you put time aside? Was the strongest predictor of a person's diabetes control. Very interesting. And this is another study we did from a terrific PhD student in our department, Rhonda Garrard, looking at Somali, Indian, Chinese and Australian residents. We were hypothesised that the Aussies would have the highest health literacy as compared with our immigrant groups. But what we found surprising was the Somali had the highest health literacy. Wow, less educated. And they had come from a lot of war-torn homes. Very tricky. Why is that? Well, it's because their expectations were that if you go to a doctor, they won't talk to you. It's actually very hard to find a doctor. It's too expensive anyway. All these experiences through the qualitative work associated with this quantitative was that it's a great experience to have healthcare here. Do they really have high health literacy? Do they have a lot less knowledge? But they're an incredibly close-knit community. You find one expert in that community on diabetes, and everyone goes to that person for diabetes. They may believe that taking limes is the cure for diabetes, because diabetes is about too much sugar in your blood, so take lots of lime, therefore it reduces your diabetes. So all these very close communities can be very strongly supported with good health, but also it can actually be a negative, we found, in these particular communities. So I often have to get hassled about what's the difference between health literacy and health education, but very quickly, health education is largely about health providers and policymakers and the messages that we think that that we should convey to people. But health literacy is more about understanding people, like the nature of the soil. Health literacy is a bottom-up perspective focused on understanding people as lifelong learners and their differences. It relates to all health decisions they make in their life, not just the ones that we're focused on as providers or researchers. But why understanding the soil matters? Well, we need to choose the right type of seed. The health literacy analogy is about, well, people need what to do information, how to do information, and why to do information, give them a much better chance of actually doing it. We don't usually take this kind of structure to the information provision. And then in preparing the soil, like removing the rocks of distrust or the fear of doctors and healthcare professionals, or the basic concepts of the body, diseases and health services, do people actually understand that antibiotics do particular activities, particular actions on the body? It's very hard to get involved or want to do something if you don't really understand how it has that particular effect and you can't understand the words the doctor or health professional is saying. The method of planting, self-search for sources, printed materials, oral delivery and group settings are all different ways we can plant information and supports for people. And then in caring for the seed as it grows. Dealing with advertising, the soft drink, the weeds, or conflicting advice, the competition for sunlight, you could say, immense competition for messages going to people in the community. And then checking the growth and adding food and water when necessary, giving encouragement, tips, reinforcement, extra advice, activate social support, and then actually problem solving. These are all different ways which we can organise how we work with people in the community so that they have a much better chance of understanding health and taking action. Quite often a lot of our interventions might just be about giving people more information, more printed materials. So across the top here we've got the elements of health literacy, being able to access, understand, appraise, retrieve or remember information, or applying their skills. Down here, printed materials, talking with health staff is another intervention. Media, TV, radio, the community conversations, the conversations that people have on a daily basis around the dinner table, down the pub, at the footy, at the soccer, at the rugby here in Sydney. Also ICT, internet, social media and apps, they get information from there. It's another way of doing intervening. And arts and songs and plays. So when we're doing interventions, if we just do one element of this, we could be missing out on a completely huge segment of society because they just don't learn that way. So our interventions need to be multimodal. A big key thing of the WHO and the 13th Programme of Work and the Shanghai Declaration, all these great declarations, is the big catch cry of leave no one behind. So if we're doing a health promotion in our clinical interventions and we're really considering all the different learning styles, all the different capabilities of people, we have enormous opportunity to leave people behind. So I'm thinking around the interventions and the skills that people can have, we can begin to build interventions that do understand and meet the needs of everyone in society. So thinking about health literacy intervention development, I'm an epidemiologist as part of my background, done a lot of measurement, getting really bored with that and thinking about social inequalities, what I'm doing isn't changing the world, but I realised there was a bit of a problem. I cannot go to the literature and get a health literacy intervention off the shelf. It could have been built in the UK or the US or Cambodia or somewhere, but it doesn't suit Melbourne or doesn't suit where I'm working in Northern Australia. There's nothing out there that might fit my particular clinic or culture. I realise there's nothing new in health literacy though. It is what great frontline practitioners do every day, but it is also what some great families do every day, or some great individuals do every day. You can have two people living side by side, different households, in the same economic condition. One family has a healthy set of habits, or have changed to healthy habits, another hasn't. What's special about that family who has changed? There's so much we can learn, we can extract from community. There's nothing new under the sun, really. So our mission towards intervention development and health literacy is to find and extract local wisdom and make that, and great practices, and make that usual practice. All of us at some time, I assume, have been to a doctor, or actually at least to a manager, who will sit down and, well, the story is better when a patient walks in, they're green with yellow spots. The doctor sits down. Gradually, they become green with yellow spots. The patient really feels listened to, understood. They can hear and understand, they feel empowered, they leave knowing what to do. The next person that walks in is blue with yellow stripes. Then gradually that same doctor becomes blue with yellow stripes. And that patient feels really listened to and heard. They understand what to do. They leave empowered to go and do great work. So there are extraordinary individuals out there. There are extraordinary families. There's so much we can learn from a community already. So again, this is like a grounded approach, really understanding what's happening in a community. So in our work in developing health literacy measures in Australia, as we began to work more and more in cultural and linguistic diverse groups, and also in Asia with the WHO, we really come to see that we could do something different there. So the way in which we develop questionnaires is put up a very general concept. Thinking about your experiences and trying to look after health or the health of your family, what does a person need to be able to get and use all the information they need? It's a very general concept based on the WHO definition of health literacy. And through a very egalitarian, a very grounded approach, the community comes up what are the dimensions of health literacy. And what people in Asia came up with, this is actually in Thailand, north, east, west and south, also a huge number of people who are blind and deaf. These are the dimensions of health literacy in this particular setting. Some of them are quite similar to what we developed in Australia, but the big difference is here. In communal societies, there's a very different way in which information is conveyed. So I work here in Australia with some of the Asian communities. It is really quite different because they're thinking about things differently. Often it's the family head who makes a decision, or it's the mother who makes a decision, or the grandmother in some communities making a decision. All these decision making can be quite different. So in our work in developing interventions, so I've become obsessed with the process of developing interventions that are fit for purpose, that just slip into practice. We don't have to actually force it into practice. So much of our research in NHMRC, and one of my principal funders is the NHMRC, I'm a principal research fellow, is that we tend to develop an intervention from someone's good idea, or we saw it in someone's research paper somewhere else, and we do an RCT, and then we have our intervention proven to work, and then we try to put it into practice. It's like finding a square hole and putting a round peg in it. I'm dyslexic, I got it any other way, wrong way. So what we try to do with our work is to work with local stakeholders, get all of them really engaged. Then do a needs assessment. Let's find out the micro details of people's ability to understand, access, engage in information and services. So that's the questionnaire we developed. Out of that we get a very fine-grained information about what to do. Then we use small group activities to find out the local wisdom from people. Then we do further intervention design and co-design and communities of practice, and we test, evaluate and plan, study, act, do cycles. So ordinarily when you get a questionnaire back, you'll get just averages from something, but this doesn't tell you anything. You can't really tell whether it's high or low. None of the health literacy questionnaires have anything empirical about them saying why something is high or low. It hasn't really been tested to deaths or poor outcomes from communication. They're just assumptions. So even our questionnaire is pretty useless if you just give means out there. We can give you sort of with a sense, high and low from response options, but that doesn't really mean very much either. We can say high and low, but not based on evidence. But what we can do is do a cluster analysis. We can actually find out the subgroups of people out there with the same levels of health literacy. And what I mean by that, here's a questionnaire result. The software cluster analysis will begin to group people with exactly the same scores on the questionnaire, and gradually the software comes up with the subgroups and community. They all have different patterns of health literacy, and here is a cluster analysis. So there's a group here, perhaps all high health literacy, and there's middling different types of health literacy, and here's a group with mostly low health literacy. This is actually work done in Egypt, and here we have in Egypt, generally in that society, everyone has got really quite strong social support, but here's a group here with middling social support, which could be a very profound determinant of all their ability to go to a doctor and be supported and survive in the complex healthcare environment there. So out of these strengths and weaknesses, we mix this with demographic data, and we can come up with a vignette, a real live story of all the different kinds of people in the community. And out of this, we just ask simple questions of community. Given the profile of Ahmed, who's a 39-year-old fisherman, and on the goes with the pictures of his health literacy strengths and weaknesses, we can get an immense range of ideas. How can we help people like this in the community, or what could be done? If there's lots of people like this in the community, what could be done or is being done? And from the community and best frontline practitioners and the managers, everyone's putting input into this, and we get literally hundreds of ideas that are built in situ in the community, which we know they're going to work because they're built in the community. All these ideas are organised according to this framework. This whole approach is called Ophelia, Optimising Health Literacy and Access, that we built in Melbourne across 9 healthcare services, now reproduced in about 30 sites around the world. These ideas are organised, and what changes have to happen in individuals, what changes have to happen in staff, what changes have to happen in community engagement, what changes have to happen in organisations. Out of this, a whole detailed map of the interventions are put on the table. We did this work most recently with breast screen Victoria, because in the northwest of Melbourne, there's very low uptake amongst Arabic-speaking and Italian women, about 5% in response to particular letters being sent out. So the community did this big co-design initiative and come up with 244 ideas, and the breast screen tested 7 of them, and 2 of them were actually ringing women in language. So when we rang women in language compared with the usual practice, sending the letters, it was a 10 times increase in booking. 10 times increase. I don't expect to see an effect size like that again in my entire life. You don't see this in research. Such a big, simple thing of just getting a bilingual researcher or bilingual worker in to ring people in language. A lot of women did change to English, but just the profound respect of just calling someone in language to come and take a breast screen examination. Another tricky about health literacy is that it isn't linear, really. We've been finding that people with high and low health literacy are more likely to turn up at the emergency department. So a lot of our research is correlational research, just observational. So people with high and low health literacy. So a lot of the correlations are quite weak. But when you look at the patterns of kinds of people out there, there's different patterns of health literacy out there. This is a strong determinant of where we need to go in this area of research. It's not linear. So this cool product that we've developed in Australia, part of our work with the WHO, we've set up national health literacy demonstration projects, and these have been undertaken in many parts of the world. And eventually we'll be having 30, 40, 50 health literacy interventions, 60, hundreds we expect. And they're all developed using this very clear framework, understanding the mechanisms and the particular sets of interventions right across the system, from the micro to the macro. Out of this, we can do very careful mapping of what's going on across many, many interventions. Ideally, someone in Blacktown wants to do something on diabetes, they can do their needs assessment, plug it into the digital system we're building. They can see 16 other interventions around the world who've done diabetes in somewhat similar populations, and they can then access this website to see, people like me, operational people, have done interventions like this, and they've worked for these reasons or not worked for these reasons. So that's a very exciting thing that's happening. There's a whole European network of this being launched very shortly in January by the Portuguese government and the Russian Federation. It's really moving, and we're hoping to get some substantial demonstration projects happening in Australia So hopefully some funding will come through for that. But this software and this technique is available to anyone around the world. So I just need to wrap up. I guess a little bit of a highlight of some of the things that we're doing is that we're really very keen to, irrespective of a person's health literacy, irrespective of their health literacy, the healthcare system can respond to them where they need detailed interventions or other supports, or they need more written information, or the whole staffing structure of an organisation, the leadership of an organisation can respond. So we've built a system, a tool, responding to the different domains of an organisation such they can be really supported. This is another terrific work by one of our PhD students, Anita Trezona. So we have a tool which supports an organisation to engage in self-rating, talk about things they're doing well, and then things that they can improve. So this is across the whole organisation, a simple system using best practice in quality improvement. It's being used in Victoria and a couple other places in the world. So that's available too. And then to wrap up, a new exciting thing is digital health technology. So we were able to do this grounded approach to work out from people in the community what is their digital e-health literacy, a big co-design project with Copenhagen University and Deakin University and consultation right across the world and with lots of different patients in the UK and in Denmark. And what people come up with is a whole range of key things that are determined for their digital capability. Elements around individual, the ability to process information, engagement in their own health, and the system-related factors, access to digital services at work, and digital services that suit individual needs. And then the interaction, ability to actively engage with digital services, feel safe and in control, and motivated to engage with digital services. So when we combine this new measure about the micro elements or the different things the person's in their lives with the health literacy questionnaire, we come up with a digital or a e-ophelia process, which we're doing currently in partnership with a PHN and the Digital Health Agency of Australia. So we can work out how really can we engage deeply, have all appropriate systems and services in place such that we can implement the My Health record. Hopefully we'll see that early next year. So that's another tool that's available also. We have other tools and other processes from our WHO Collaborating Centre at Deakin, but that's all I have time for today. Thank you.